Situations and conversations with Trey Renee. Real situations, real conversations. Empowering the community leads to elevation. Entertainment and education, no better time than now. Pure enlightenment for the crowd. This is Situations and Conversations with Trey Renee.
Today on Situations and Conversations, it's our continued conversation around fibroids. Every woman's body tells a story of strength, resilience, and sometimes silent struggles. Join us as we highlight Bloom the Agency's Fibroid Wellness Fireside Chat in conjunction with Oregon Health Authority to bring awareness to this important situation. Buckle up, buttercups. A very real and raw conversation starts now.
As we begin our Fireside Chat, I'll guide us through a few core questions, and then we'll open it up for the anonymous questions that was written earlier today. So, what drew you to the work that you're doing now in the women's health and wellness?
So, for me, to be honest, my great-grandmother raised me with the knowledge that her grandmother, was a sharecropper midwife. And what they were able to do with nothing was, still awe-inspiring to me. And my great-grandmother said that only black women are going to save black women. And if her grandmother could do all this with little education, there's no reason why I couldn't do better care for people who look like me with more education. And so at first, when I was younger, I thought that just meant babies. But as I've gotten older, I realized that's not what she meant at all. She meant from the time we are coming from the tutor all the way out to the rooter. So.
I love that. And Dr. Mary?
Yeah, sure. So my family comes from Iran. Both my parents immigrated back in the 70s, and I've learned both of my grandmothers were lost due to conditions related to pregnancy. So one of them when she was pregnant, and my mom was a 4-year-old, and one of them due to severe postpartum unrecognized mental health issues. And I think that what I've learned in my sort of lifetime is that when the mothers are taken care of, the families are healthier and better. And so devoting care to the mothers in order to then be able to turn around and care for your babies and your children has been the focus of my work.
I love it. I love the fact that you have personal experience to guide you through your true purposes, right? And for the fact that you always heard just that compensation of, oh, my mother had a hysterectomy, so I should have that too. I mean, I remember when my mother had hers and there was no explanation of why she needed to have it. And I was just like, is it my turn? When I turn, in my 40s, would that be it? Is that going to hand off to my daughter? Those type of things. What are some of the most common misunderstandings or overlooked truths about fibroids in this practice?
People come to our practice, my practice, our practices, I'm sure, and they've heard about fibroids. Maybe they had a family member that had fibroids. They know their mom had fibroids. A couple of things that come up. One is maybe not quite understanding what the fibroid is and how it's going to impact them. Whether or not it's a serious disease, whether or not it's going to become cancer, whether or not they can get pregnant if they have fibroids, whether or not they're going to be able to save their uterus if they have fibroids. I would say that those are some of the big ones. People come in with confusion because there's a lot of messaging out there about what a fibroid is and how it affects you, and also all the different potential ways to treat it. And maybe those treatment options haven't been adequately explained. And so people come to us with ideas they're like, my grandma had her uterus out, my mom had her uterus out, I think I'm going to have my uterus out. And they sort of come to us thinking that that's the next step. And so that's a big one, I would say. Yep. You agree?
So I totally agree. A lot of times what I tend to hear from my patients are similarly, my grandma had fibroids, so I have to have them. My grandma had fibroids, I had to have a hysterectomy. All the women in my family have to have hysterectomies. I can't have a baby if I have a fibroid. So those are the most questions, the most common misconceptions. The other ones that I'm hearing a lot of also is there are ways you could treat the fibroids, like holistically, which is true in some instances, but actually having to drill down to what is reality versus what is TikTok nonsense it seems to be taking up more and more time, I would say.
What would you say to people that, need to be able to share their stories? Like, what does that look like for them? And like, how do you show up for your patients and like, be able to draw out that story from them? And what does that look like?
I know for me, a lot of times, I think it depends on how we approach patients. And so my approach is when patients come into the room, my mentality is when the door closes, you're no longer a stranger or just a random person. You're my family. So I talk to you like you're my family. I ask, what do you know about your family history? How old was your mother when your mother went through the change? What does that mean? What does the change mean? What was your menstrual cycle like? What to you is normal? And then listen when people tell me they've been in pain for years and we're told that was normal. And then I let folks know that's not normal. You're not supposed to be in pain. You're not supposed to be bleeding through 100 pads per cycle. That's not normal. And so just being able to listen to people tell me what their experience was, to validate when they say no one's been listening to me, and for me to be like, yeah, you're right. They were not listening to you. And then to explain how, to be very honest about how racism and bias impacts our medical care as Black and brown women. Even having that discussion, I think sometimes helps to make people feel more comfortable and know they're going to be heard, and then we can actually talk about what is the science behind fibroids, what is the science behind heavy bleeding, and kind of work from there.
Yeah, and I mean, even though we kind of make fun of TikTok and the things that are out there, YouTube and social media, I have to say, I do think it's getting people talking more. Like we're seeing it in women's health in general. We're seeing it with menopause. At least we're having these conversations now, because I think our mother's generation, they really didn't talk about things. And the fact that you could have your uterus removed and not know why, or that I'd be like, well, were her ovaries removed too? Well, we don't know. I mean, as if the ovaries don't matter, right? They're like the seat of your hormones, right? So back in the day, it felt like the doctor would tell you needed something, and then the patient would just go along with it. And I think what's happening now, which is a really great thing, is that using our phones and our videos and seeing that people are out there talking, now we're talking to each other. So when my patients come, I like to ask them, like, what are you all talking about? What are you and your friends talking about? Is what you're experiencing different than your friends? Are you the only one that brings like a change of pants when you go out for the night or something? Because you don't know if you're going to be able to go home wearing the same pants that you showed up in case something happens and you end up bleeding through. So asking those kind of like, what's your life look like questions. And I think we both understand that it doesn't always feel like that when you go to a doctor's office. Not everybody feels like their doctor wants to hear sort of the real life of it all. But part of this conversation is to let you all know that it's okay to actually know that you deserve to have those conversations with a medical professional. And if you're not having those conversations, then it's okay to try to find that for yourselves.
Yes, I think for a lot of us, fibroids, when it's mentioned, is new. Like I've never knew about fibroids until I was told that I had it. And so what advice would you give to someone navigating medical appointments and advocating for themselves through this journey for the fact that they have no clue about fibroids? So like what advice would you give? And like what are you looking for when you do have your patients that come to you?
So when people come, I ask what I say to my friends when they come to me, because they're not my patients. Right. What I direct them to do to advocate for themselves is, if you have fibroids, where are they? Ask the doctor, is it in the skin? Is it in the muscle layer? Is it in the endometrial cavity? Because the location of the fibroid will give you your symptoms. That's what determines the symptoms you have. I also ask other things like, what is the size? Don't have somebody tell you it's a golf ball size or a grapefruit size. What is the actual measurement of it? Another thing that I think we should be really, that's important, I want to bring this up, is it's important to think about getting a second opinion. If you talk to a physician and they're saying, well, and you're saying, what can I do for minimally invasive? Because there are minimally invasive routes. What can I do to preserve my uterus? And their response is, well, you're 35, you're done having kids, right? Just have a hysterectomy. You should not do that. You should perhaps get a second opinion. And I think that's what I talk to my friends about a lot, is make sure that you are asking for these questions, asking for all the minimally invasive options, asking for details, so that if you were to go home and talk to your mom, be able to tell your mother exactly where their fibroids are and why each level you cause each symptom. Because when you, at least if you know the information, you become an informed consumer or informed patient, and you're less likely to fall victim to someone else telling you that your 1 centimeter fibroid, removing that's going to leave no uterus behind, which is what we hear all the time.
Exactly. Dr. Mary, can you please tell us exactly what fibroids is and what uterine fibroids is, and anything other symptoms that come along with that?
Yeah, so in my clinic, I have a whiteboard, and so pretty much every patient gets to see me draw badly on a whiteboard, but I think it helps, right? It doesn't have to be a pretty picture to understand, and you can see some of the pictures around the room, but I tell patients, a uterus is more or less the size of my fist until it grows a baby in it, or until you get into menopause. So when you grow a baby in it, it gets bigger, and then once you go into menopause, it can shrink and be as little as a walnut, actually. But the average person that comes in the room between, the ages of 20 and 50, their uterus is about the size of my fist. Now, a fibroid is just a benign growth, and it is very hard and firm. It does feel like a golf ball or like a pebble. They can be as tiny as a pea. And I had somebody come in recently, and I'm just going to tell you that she didn't think she was coming in for fibroids. She thought she was coming in for something else. And I was doing her head to toe, did the tub, this exam, did it going down to her belly, and her belly went out to here. It was like she was carrying a baby in her belly. I knew it wasn't a baby. It was really, really firm and hard. So it's like if you push on something like hard as a rock. And I asked her, I was like, did you notice that your belly was growing? Because sometimes, being afraid of what might actually be happening will stop people from actually acknowledging. She told me she wore elastic pants, and so the pants were stretching, and so she hadn't really paid attention. And so the point of that is that fibroid was probably close to the size of a basketball. So that's how big they can get.
Yeah.
And what I tell my patients is there's different locations. So what I'm drawing on the whiteboard is I'm like, they could be Mickey Mouse ears. So Mickey Mouse ears are sticking off the top, and those tend to not cause bleeding, but they can cause pain or discomfort if they're big enough and they're pushing on other things. They can push on your bladder and make your bladder small. You're peeing all the time. They can push on your rectum. People can feel them in different situations. And then there's the fibroids that are inside the muscle. And again, depending on how big they are, those can also cause pain. The ones that tend to be bothersome for bleeding are pushing into the actual cavity. So the cavity is where you grow a fetus, right? That's where we bleed from. That's where the lining, that's the huge blood supply. And so the fibroids are like, they create a little blood supply of their own. So it's like you have this little thing, a little ball that's growing inside of your uterus with extra blood, and it can cause a lot of bleeding. So those are fibroids. They're almost 100% benign. Very, very rare for them to turn into cancer. So it's really important to understand that they're almost 100% not cancer. So you don't have to be scared of the cancer side of it, but depending on the symptoms and where they're located, there's going to be different treatments. And you have to have somebody that's able to talk to you about all the different treatments based on yours. So what I'll do also is then I'll pull up their ultrasound on my computer, and we'll actually look, and I'm like, these are your fibroids. So this is my generic whiteboard picture, and now these are yours, and these are where yours live, and this is how big they are, and these are the treatment options.
And then what are the treatment options? Can you speak to that, Dr.
Before we
Kim?
go to that, I'm going to go back to one more thing.
Sure.
So here's something that I realized in our community that we may not know. Fibroids are only in the uterus. I think we've probably both heard, well, my mom had fibroids on her ovary. No, you don't. And the reason why we know they're not on the ovary is because they arise from a gene mutation in the smooth muscle that programs for the smooth muscle of the uterus. So that's where they arise from, and they either deliver out to the skin of the serosa or into the endometrial, the cavity that we're talking about. Sorry about that. So they either go out to the skin, which is serosa, or into the endometrial cavity or the soap mucosa. So you don't have them in the ovaries. You might find, when we do a hysterectomy or if we're doing a myomectomy, when you actually go to take the fibroid out, you may find it down near the skin by the cervix, but they don't arise in the cervix. So I want everyone to know fibroids are a beast unto themselves within the uterine cavity or within the uterus itself, just so you know. And then the treatments, there's a lot of different options. You have your minimally invasive options. So minimally invasive means without surgery. And of course, you have your surgical options, and you also have your medical options. So if you just start with the medical options, one of them is an IUD, a progesterone-containing IUD. All right, sisters. Now, I know a lot of us have mothers and grandmothers who have told you, you bet not never get an IUD. And I know that because my mother said that to me. And I was like, girl, stop. OBGYN here, please stop. Historically, and yes, we do know that historically the first IUDs that came out in the time of our moms and our grandmoms was the Liley's Loop and the Dalcon Shield. Those guys they caused scarring inside the uterus. They caused, people had to have hysterectomies. They caused infertility. That is not what we're dealing with now, and we have not dealt with the Liley's Loop or Dalcon Shield since the 1970s. What we have now are very inerts, for the most part, IUDs. They look like a T, so they kind of mimic the inside shape of the uterine cavity. The one that specifically does help to decrease the growth of fibroids is the progesterone-containing IUD. Progesterone is a hormone, but the thing that's important to know is that it works locally. It works within the uterus itself. Very little bit of it goes outside the uterus, so you don't have a lot of the crazy side effects like you do from birth control pills. They work really well to downregulate or to turn down the estrogen receptors on fibroids. Fibroids grow because they're fed by estrogen, which our body makes. It has to. That's what the ovaries are making, right? So by turning down that receptor, you slow the growth. They probably won't shrink. They probably won't go away, but the growth slows as does the symptoms. So that's one option. Another option is you can do birth control pills. A lot of times we tell people you can do it, and again, it depends on location. So if they're in the muscle layer and you just don't want them to grow, you can always do birth control pills. If they're in the endometrial cavity, a lot of times people will try to use birth control pills as a first line option, but a lot of times it doesn't really work very well because you literally do have this fibroid, like Dr. Mary was saying, trying to invade into the cavity with its own blood supply. It's not going to work very long. You also have uterine artery embolization, which is also being called uterine fibroid embolization, where you go to see an interventional radiologist. They're able to actually put imaging on, see what the blood supply is to the fibroids, and shoot these little BBs into the blood supply for the fibroids. Over time, they die off. Did you hear what I said? Over time. I'm not talking about a year, 6 months, 3 years, 3 months, over time. So years it could take for it to get smaller. But depending on the location, it's a really good viable option. And it's an option that is not offered to black women at the same rate as it is to white women. Did you hear what I said, my sisters?
She sure did.
Okay.
She said it.
So
yes. Right.
So it's something to remember to ask for. And of course, myomectomy is another option. There's different kinds of myomectomy. One is an open, where you open your belly to get to it. If it's on the outside, you can do hysteroscopic, where you go in through the actual cervix into the uterus, blow it up and shave it out. And of course, there's the different methods too. There's the Accessa method, where it's a combination of hysteroscopy, laparoscopy, and radiotherapy, which is a minimally invasive route. And of course, then there's Listetto, is another medication, otherwise known as TXA, which helps you take it while you're on your cycle, only for heavy bleeding. It helps to decrease how much bleeding you have during your cycle. It does not necessarily impact the growth of the fibroid, but it makes the symptoms better for the internal fibroids. Sorry.
Wow, thank you. Dr. Mary, how does fibroids come about?
Yeah, I mean, I'll speak to the best that I know, and you can feel free to jump in if you know more than I do. We do think that there's a genetic component. I mean, we do see it largely, and basically, if you look at African populations, that's probably the largest percentage of people that grow fibroids are seen in that population. We think that there might be an increase in Middle Eastern populations and some Asian cultures as well. We don't 100% have like an explanation 100%, but there is like an estrogen component. So there is some thought that possibly increased stress that increases cortisol can increase estrogen production. I hate saying that because I never want to blame the person that has the fibroids. I never want to be like, well, you're too stressed out and that's why you have your fibroids, because that may not be true. Okay, we're not talking about like, oh, you're so stressed, don't be so stressed and maybe you won't have fibroids. I don't mean it like that. I'm talking about systemic stress. I'm talking about historic stress. I'm talking about generational stress. Okay, so we're talking about a different type of stress. Okay, so that's what I'm referring to in that. There's some thoughts maybe about vitamin D, maybe vitamin D deficiency. And so definitely in folks that have higher melanin in my culture and in Black culture, like taking vitamin D is important because we don't absorb it as well. So those are some of the theories behind it.
The theory, especially for those of us whose forebears survived the Middle Passage, is it was an evolutionary adaptation for how women avoided getting infected with malaria. By having fibroids, we bleed heavier. By bleeding heavier, our hemoglobin hematocrit is lower. Therefore, when you have malaria, the spirochetes are less likely to be able to form in our red blood cells. And so that was another really good theory as to why so many of us have that gene. And if you look at it, if you look at mainland China, they also have parts that are under the equator. They also have the same rates of fibroids as we do. Same thing with our sisters in South America, have the same rates of fibroids as we do.
How can women support their fertility and pregnancy while fighting fibroids?
So I guess the question is, and this goes back to knowing exactly where the fibroids are. Are we talking about fibroids on the skin level? Are we talking about fibroids in the muscle? Or are we talking about fibroids in the cavity? So the only ones that would really impact pregnancy are if it's like in the cavity and the placenta can't get attached, or if it's maybe in the cavity, the placenta's on the opposite end, but it's large enough where and in the right location where the baby can't come out because it obstructs the outlet. Or same thing if it's in the muscle layer or the skin and it obstructs the outlet. So the baby can't get out, or we have to talk about in the C-section. Or if you have a fibroid burden what's greater than 5 centimeters, both in the muscle or the serosal layer, one thing you do have to be concerned about is as you're heading towards 24 weeks and beyond, because your baby has outgrown, the blood supply is bigger and it's taking more of the blood supply, that sometimes the fibers themselves get necrotic, which makes you more crampy, you have a lot more discomfort. Right. Doesn't necessarily increase the risk of preterm labor, but you feel like you're in preterm labor because it's so uncomfortable, and there's not a whole lot we can do for your pain. You can't give you ibuprofen when you're pregnant. Right. You know what I mean? So in regards to protecting fertility, if you're already pregnant, so you should be fine if you already have them. A lot of times I try to talk to people before they get pregnant if they have fibroids. We can talk about what is pregnancy going to look like, what can we do to shrink or remove these fibroids before you get pregnant, which fibroids actually will adversely impact pregnancy. And so you want to plan beforehand if you can. And don't let them take your uterus out.
Don't you do it. What strategies have you seen work best for improving informed decisions making, especially when patients are overwhelmed by treatment options?
I give people a lot of stuff to read.
Okay.
Either I print it all out for you, which kills a lot of trees, or I will give you the links so you can read yourself. I like people to read it. If you're in the room with me for 30 minutes, I'm trying to get through stuff. It is rapid fire, and it's hard to absorb all of it. But if I give you stuff to read, and all the stuff I give you either is from ACOG, so ACOG has a lot of their own patient-centered information. That way it's actually broken down, so it's not like doctor speak. There's also information from the Mayo Clinic that does a really good job of explaining a lot of options. Johns Hopkins also has a lot of information, FAQs that I tend to give out. So I give lots of stuff for people to read because I feel like at any time you can just go through and look. And then you can also ask questions. I get a lot of questions through my chart, and I'll stop and break it down and answer the questions again.
Yeah, I think I will tell my patients when we first start having these big conversations with lots of options that you do not have to make a decision today. Because I think people start to feel like, oh my God, I have to decide if I'm going to have a hysterectomy or a myomectomy or da-da. And I'm like, we don't have to decide that today. Like today and I call it downloading my brain. I'm like, my job for you is for you to know what's in my brain. Because if you don't know what I'm thinking, then you don't have all the options, right? You don't have no way. So I'm going to download my brain to you. I'm going to share with you what I think all the options are going to be. I might even tell you what the few options I think are best for you, after an informed conversation, whether you want to have a baby or not. Like I could give you some options there. And then I ask you to go home and think about it. And then we always, and I think through my chart and then through our messaging app, we provide a way for patients to then message with us. So like a couple days later, they might be like, you know what, I was thinking da-da-da-da-da. Or maybe they need to have another conversation. And then we do it that way.
Yeah.
But don't feel like you have to make a snap decision.
Thank you all for showing up. Thank you all for sharing your stories and asking questions.
And I just encourage you guys, whatever you learned today, just go tell a friend. We always say bring someone with you. Go tell someone about what you learned tonight, and hopefully it can change and help them bring more awareness as they are spreading that information out in the world as well. So thank you.
And let me tell you something. We need to be talking more about women's wellness and in particular, fibroid awareness. I literally was telling somebody I was coming to this event and they were like, what's a fibroid? Exactly. Whole reason why I love the fact that my sister, a BBAT, a Bloom agency, put this together. So necessary for the community, for everybody. You don't just have to be a woman. There are women in everybody's lives. You can all benefit from this information. So please make sure that you stay on top of it. Click all the links, all the things, because this event was so informative and so amazing and such a collective of community. I loved it. Mwah. All right, family, that's our show for today. Thank you so much for hanging with us. I love and appreciate you for it. God willing, we'll be back next week for more. In the meantime, make sure you take excellent care of yourselves. That's the only way you'll be able to take care of anyone else, which is our mission. When you think me, think we. When you think you, think too. See ya. Thanks to our presenting sponsor, Oregon Health Authority, helping people and communities achieve optimum physical, mental, and social well-being. And thanks to our supporting partners, Louisa, a community-centered event space in the heart of Northeast Portland, and Adorn Boutique for my fabulous wardrobe. Situations and Conversations is a Trey Renee production in conjunction with Thomas Chung Films. Watch Situations and Conversations with Trey Renee Sundays at noon on Portland CW and streaming on the Coin Plus app.